Thanks for volunteering. Yeah, so my name's Tom McCary. I'm a mental health clinician and live and work in upstate New York, about an hour and a half north of the city. Um, I'm a person in long-term recovery and have lost friends, family, community members, and clients to both overdose and suicide. So this is something topic which is very personal to me, and really the motivation behind the work that I'm looking forward to sharing with you today. I do have some slides I'll share. And we've got a small group. I'm going to do my best to make this interactive, but also do not hesitate at any time. I may or may not see a hand raised. Welcome to just take yourself off mute and chime in, or drop questions in the chat as well. One more thing. Okay, awesome. So as I mentioned, I'm the co-founder and CEO of Zero Overdose. We're a small nonprofit organization with the goal of reducing or preventing overdose deaths and events. And what we have done is adapt some of the evidence-based tools which have been shown effective for suicide prevention to help support organizations, clinicians, communities in implementing and integrating harm reduction into the work that they're doing. So we have do a lot of work with the New York State OASAS, which oversees all the substance use treatment programs in New York State, and also the National Council for Wellbeing in doing training and technical assistance with certified community behavioral health organizations and harm reduction programs. And I just like to share, because I'm so proud of the team that we've compiled. We have a really diverse team that is clinically diverse, life experience diverse, and live and work in a wide across the whole country and beyond. And so that's been a really exciting part, coming from just two people, Verna and myself. We were working at a federally qualified health center up in upstate New York. And what we found was, like echoed across the country, overdose deaths were significantly on the rise. And in fact, in Ulster County, where we live and work, we were the highest rate of overdose deaths in New York State at that time. And she tasked me with sort of going out and finding what types of clinical tools that we could use to help train the other staff. And we were deeply embedded in as a zero suicide organization, and very comprehensive care pathways for people who were at risk of suicide. Linkages with the emergency rooms, use of screening and assessment and safety planning, just baked into the electronic health records and the work that we do. What I found was there really wasn't much out there. There was Narcan, which is the emergency overdose reversal medication after someone's had an overdose, and there's medications for opiate use disorder like buprenorphine, methadone, Vivitrol. But after that, there really wasn't much that was available. And so I started to look to say, okay, well, what's working for other types of preventable death? And so we started adapting and modifying suicide evidence-based practices for suicide prevention. That's where we started, and I'll just share you a little bit about where we've gone. At the end of the day, this is not just a regional problem. It's hard to find a room full of people or anyone has not been impacted in some way by the overdose and opiate epidemic. And what is driving this now is really the prevalence and profound um, flow of fentanyl into the country and into the substance use supply. Compounded with that, is that the vast majority of people who meet the criteria for having a substance use disorder are not in care. And so really what our aim is mobilizing, anyone who works in any capacity with people at risk for overdose, is to integrate these types of harm reduction practices and develop the language and clinical tools, clinical skills to talk with people about overdose risk. And because what we also are learning more is that more and more through doing fatality reviews is that there are indications, right? There are opportunities to intervene in a lot of circumstances. And we play a pivotal role. And I can say that I don't know what your roles, all of your roles are, but whatever role you have an important role in helping prevent overdose deaths. And I'm not going to talk too much about the statistics, because we have a short amount of time, and I really want to share the safety plan and the solution which we're working towards. But it's an important part of it is also being able to share data in a way which strengthens the clinical experiences that you're having. And so, and also sometimes dispelling myths. How do we, we don't have to be experts in harm reduction or data, but being able to dispel some of the myths which might decrease somebody's likelihood of taking action. Right. So we know that overdose deaths seem to have peaked in the 12 months that ending in about February of 2023. There has been some data since then, which there has been some decrease in overdose deaths over a 12-month period. It's helpful to share that this is not necessarily a downward trend. Like we don't have to. I say. I'll say all of this is to say that we can't lose the urgency behind addressing the opiate epidemic and overdose deaths, right? 102,000 people a year is a profound number. And while overdose deaths seem to have dropped at a most recent data collection, overdose events still are increasing. And so this is a little bit has to do with the proliferation of Narcan as an emergency reversal medication. It's very important. However, I think we can do a lot more in preventing overdose events in the first place. So not all. I think it's really important that the first, just the top line statistics of how many deaths are occurring, it doesn't really tell the whole picture. When we look one layer deeper, it really highlights that there is a very specific driver behind these overdose deaths, and it's the prevalence of synthetic opiates like fentanyl and carfentanil. And this is being mixed in with pretty much all substances of misuse, a huge increase in fake and pressed pills that look identical to medications. And so with that, people are being exposed to high doses of very potent opiates who are not necessarily even seeking out opiates or have any tolerance to opiates. They might be looking for, think that somebody's given them an Adderall to help them study, right? They might think that they are, using a different type of substance, but that fentanyl is mixed in, right? And so looking even a little bit closer at it, this is this picture on the upper left is an approximate of a fatal dose of fentanyl. It's about what they kind of consider 2 milligrams. If somebody is opiate naive, meaning they don't have any tolerance to opiates, they're just exposed to it, 2 milligrams is likely a fatal dose of fentanyl. And when I mentioned the increased amount of fake or pressed pills, this website is I recommend. It's the DEA's One Pill Can Kill campaign, and it has a lot of good resources. About 7 out of 10 pills, fake pills that were confiscated by the DEA have a fatal dose of fentanyl in them, right? And this is not necessarily this is not necessarily fake oxycodone or opiate. This is just any fake pills that are being made, right? And this is driven by the fact that it's very inexpensive to produce and highly available. I just grabbed some headlines back in December, but these were all within just a few weeks of when I did this collection. And really with the intention of just demonstrating that wherever you live, this is probably occurring. Right? I'm in the Hudson Valley. A few years ago, there was a headline, enough fentanyl to kill the village of Ellenville 3 times. This is like profound amounts. And pretty much wherever that is kind of being echoed. In Missouri, enough fentanyl to kill the state of Missouri. San Francisco, the same. All the way up to actually over the course of 1 year, there was enough fentanyl seized and trying to enter the country to kill the entire U.S. population. This is a categorically changes how we need to approach overdose prevention and harm reduction, that stepping away from the idea that this is something that is only relevant to people with a substance use disorder. This is only, IV drug users. This is these sort of have to go out the window, right? Anyone who is using substances, whether or not they meet the criteria for an opioid use disorder, whether or not they're seeking out opiates, have a risk for overdose. And as us in a helper role, play a critical part in providing psychoeducation, normalizing the conversation, and then also talking with people about what they can do to keep themselves safe. And really what I'm hoping to mobilize and encourage you and excite you about this is that the hope is not just to prevent overdose deaths, right? And so Narcan is an essential part of a community and an individual's overdose prevention sort of plan. The real goal is to reach upstream from that, and so that people are not having overdoses in the first place. The overdose safety plan is a brief collaborative. I'm just going to mute myself for just a second here and try to clear my throat. That was fun. I'm glad you can be glad you didn't hear that. It's a brief collaborative intervention. So this is not just something that you give to a client and say, here's a safety plan, go and do it. Similar to suicide safety planning, the intervention, the conversation itself has a strong therapeutic benefit. Right, we're communicating that this is something that we talk about, just like suicide. We can talk about it directly, we can talk about it repeatedly, and this is something irregardless of what our role is and what the purpose of that person's conversation coming with us. Because if they die, nothing else is going to get nothing else is going to improve for them, right? And so the aim of it is to help identify what a person's individual risk factors are that would increase their risk of having an accidental overdose, and then pair those with harm reduction strategies, overdose prevention strategies that they already are taking or are willing to consider. Overdose safety planning has gotten some traction at the federal level and has been included in SAMHSA's opioid overdose reduction continuum of care approach, as well as their more recent overdose prevention toolkit. Inherently, built into this is the utilization of motivational interviewing skills. And I really love just the inherent overlap between the principles and practices of harm reduction, which is, encompasses a huge, a very comprehensive practices, but also principles, and a way of advocating for individuals' rights and practices. So there's a really nice synergy between what we sort of are likely more experienced with it as clinicians in motivational interviewing, but thinking about how this is not different. Harm reduction is not different than how we already approach working with people, and so it's learning how to marry that language. I mean, without getting too much further, I want to show sort of what it looks like. And I know it's very small here, but I can also make sure that this is available to everyone who participates. It's just helpful to say, I'm not talking about safety planning in a theoretical way. This is an actual document. This is a one-page document, which can either be electronic or paper and pencil. It's something which can be applied to people with higher risk for overdose or lower risk for overdose. And the intention is that it's something that can be then uploaded into the person's electronic health record, shared across care teams, and it's intended to guide the conversation. What I also noticed when I was first starting to talk with people about overdose prevention, and kind of before I had this, actual document, I just was having these conversations. What I noticed was that oftentimes people felt like it was personal. They felt there was more stigma involved in it, even though that was not at all what I was trying to convey. I'll try better to give an example. I was working with somebody who came out of a substance use program, successfully completed. They had about a month of abstinence, and this was maybe one of the longest amounts of time that they had in quite some time. And I was the one who helped get them into that program. They were so happy to see me because I helped them, and I was one of the few people that believed in them. And in the back of my mind throughout this whole first session that I saw them is, man, they are at risk for having an overdose. And this was not, trying to say that I didn't believe in them, but the facts, if they resumed use, they would be at a lot of risk for having an overdose. And it's my responsibility. If I'm not talking about this with them, who else is going to be, right? So I tried as best and carefully and compassionately bring up their risk for overdose. And I saw their affect, their whole demeanor just was like shattered. Tom's just one more person who doesn't think I can make it, right? And that wasn't what I believe. I just don't want this person to die, and I feel responsible to have these conversations. So conversely, after having the safety plan, now I'm able to, in a very similar circumstance, I'm able to say, hey, when someone comes out of the treatment program, we like to do a safety plan. And I show it to them. So this kind of this is a part of the care that we do for everyone. This is not me thinking that you're going to fail. This is not, anything direct. This is what we do, and it's normalized. This is a part of the treatment that we do. And people say, oh, they have a very different reaction. Oh yeah, my neighbor's son died from an overdose. People need to know about this, right? It was a little bit separate from their own experience, but we still were able to go through the information and talk about, what that meant to come out of to have low tolerance for opiates, to fentanyl and drugs. So we were able to kind of walk through it in a much less threatening way. We also developed a kind of a companion tool to the safety plan, which is a overdose risk questionnaire. And what we found was a lot of people, a lot of organizations and clinicians were interested in having these conversations with people, but they didn't feel prepared. Well, I don't, how am I going to help them? I don't know enough about substance use. I don't know enough about overdose risk to have these conversations. So we just sort of compiled some of the most common risk factors for having an overdose. And so this is something which guides the conversation and can help inform the safety plan. We could spend more than 50 minutes just talking about harm reduction, in addition to more than 50 minutes talking about motivational interviewing. I include this both in slides, though, as something which is an important piece of it. And I encourage you all to learn more. The Harm Reduction Coalition is an excellent resource, and they have a lot of materials that you can look into around the principles of harm reduction. But I do think it's important to talk about it in that we are the importance of moving away from an all or nothing view of substance use, right? Even when someone's goal is an abstinence-based recovery, we want to support whatever someone's goal is. But the more that we can move away from all or nothing view of substance use, the more opportunities we have, not only to create an alignment and partnership and meeting people where, this is what we're saying, meeting people where they're at, right? We have more language to increase the more pathways to wellness, more language around the topics, and to get truly a better understanding of someone's life experience. Most of the assessments, right, that are out related to substance use are very diagnostic in their approach, right? They're trying to see if somebody meets the criteria for having a substance use disorder. It's important. We want to know if there's a substance use disorder or not, but it's really just one piece of their wellness, right? What does that mean? If they don't have a substance use disorder, do we not have to talk about overdose prevention? We just move on. Okay, you don't have a cocaine use disorder. You just use cocaine every once in a while, but you don't meet the criteria for it. Right? That's like, there's so much more that we can do in helping to talk with that person about not dying from an overdose, irregardless of their diagnosis or not, right? And so these are the types of things that we can get into that. Motivational interviewing, I guess, again, another one. We could have a full day or multi-day trainings on motivational interviewing, and I encourage you to continue that practice. But these are truly skills which help create that alignment, and there's so much synergy between autonomy, personal choice, compassion that is central to the principles of harm reduction that is supported through the use of motivational interviewing skills, and helping to we're talking about motivational interviewing is excellent in helping to increase the likelihood that someone makes positive change. And so that's a big part of harm reduction, right? This is their choices. We're a partner in this, and how we can help to navigate that, and also dismantle some of the fear or stigma that they may have related to the health system, related to the behavioral health system, because many people have learned that being truthful, or the disclosure and being honest about their substance use has not served them well, right? They have learned through their interactions with health, behavioral health, and all the systems that they have been a part of, that being truthful about their substance use, it does not help them. So the responsibility, the onus is on us to communicate why we're talking about substance use, why we're interested, and this is motivational interviewing skills, and the whole sort of association, the motivational, the spirit of motivational interviewing, and all that goes along with it, is a really good foundation for ensuring that it is done compassionately and effectively. So when we think about talking with people about overdose prevention, it's really helpful to think about, well, what are the things that could lead to having an overdose? So we adapted this, which is based on the drug set and setting model. But I'd just like to kind of open up the floor to, well, here I could say before I do that. So the risk formula is different sort of categories, which most risk factors will fall into one or more of these. But effectively, how much opiates are consumed, this is the amount, right? How much is consumed. The route is how the drugs are taken. Tolerance is the body's ability to, how much tolerance the person has or doesn't have. Mindset goes into sort of the purpose of the substance use, the emotional state of the person at the time in which they're using the substances. And the setting is sort of who they're with, where they're at, what are they around. And so what we feel is that most risk factors will fall into some of these categories. And it also, as a helper, thinking about moving away from all or nothing, right? Drug use, no drug use, right? The more avenues, the more things that we can think about is to gives us more different areas that we can help move people, turn the dial in lots of different ways, because some of these may be more or less flexible for the person. And so while one area they might not be willing to change or able to change, that just puts more importance on the other areas. So I know I'm just going to put this out there. Sort of, what are some of the, either you can put it in the chat, or what are some of the risk factors that you think about that for overdose? Great. History, a past history of having an overdose. Is that what you mean by that, Wendy? Family history. Family history.
Yeah, I'm sorry. I'll jump in on the speaker. Yeah, I was thinking like a family history to drug use, alcohol use, something to that effect where substance abuse is prevalent.
Yeah, absolutely. So that would increase the likelihood that somebody is going to be using substances themselves.
Correct.
Yeah. Okay. Excellent. Yeah. And Daniel's got inconsistent use, the amounts of use. Absolutely. Right. And so inconsistent use could be like episodic use, starting and stopping. Right. I've got periods of abstinence. I've got periods of resumed use. Inconsistent amounts of use, right? Anything that's changing, that could even be getting it from different sources, purity, not knowing, not different types of substances. Absolutely. Trauma, loss, loneliness, the lack of purpose, belonging, mental health, high risk environments and culture. Nikki, that is excellent. And I would put a lot of these into the mindset, right? And so, sometimes people are using substances to try to alleviate physical or emotional pain, right? And the greater soothing, yeah, great. So the increased amount of physical or emotional pain puts more pressure on the lengths we will go to relieve that pain, right? And so having an understanding of that, and also thinking about this confluence of suicide and overdose. That oftentimes we don't, when we talk with people, they don't necessarily say I was using to try to kill myself, but they might say I was using and I really didn't care if I woke up or not, right? So there might be some passive suicidal, that would make a big difference, right? If somebody's using and they don't care if they're going to wake up or not, this implies that there could be significantly more risky use than somebody who is not on that at all, not on that spectrum at all. I'm using and I'm really terrified of having an overdose, right? So this is two different mindsets, even just approaching the substance use. And one likely to be associated with more care and practice, the other maybe less care and practice if they don't really, not really caring as much. Somebody's also, Tansy also highlighted that somebody's mindset might also be impacted by mental health, like either a manic, hypomanic phase, right? That's oftentimes associated with higher risk behaviors. And relapse after titration coming down from MAT. Yeah, so sometimes successfully completing treatment or any transitions of care are high risk periods. So some other things that I oftentimes associate, these are great, these were excellent examples. Other very concrete things that could increase someone's risk for having an overdose might be using more than one substance at a time, right? So opiates, in addition to other depressants like alcohol or benzodiazepines that may or may not be prescribed or not, but opiates and other depressants is like 1 + 1 = 5. 1 + 1 doesn't equal 2. There's a synergistic effect. And so these are things to ask people about. That's what has to do with amount. So, seeking out fentanyl, right? Not knowing if there's fentanyl in the substance or not. This would affect the amount. How much opiates is the person taking? The route, right? There's lots of different ways to take drugs. So we kind of think of most, the highest risk of having an overdose is oftentimes thought of as like a syringe use, right? So with an IV, the drugs are going directly into the drug supply very quickly and in a concentrated way to the brain, right? It's very fast, very efficient. And once you take it, there's no going back, right? There are other ways of using syringes as well. There's like intermuscularly, so like just into the muscle, but not into the vein. and then also something where it can be pushed underneath the skin. So it's sometimes called skin popping. And this is less quick, less concentrated. We're thinking about how quickly did the substance get to the brain and to the receptors in the brain. If there's too much over a short period of time, it's going to lead to an overdose. So anything that decreases the amount and increases the amount of time over which the drugs are being taken. So other types of use, smoking, a little bit is less risky, snorting, inhaling, and swallowing, right? So there's kind of like a hierarchy. If we can help people move to less risky ways, even if they're using the same amount, but they're using switching from a syringe to snorting would be significantly less risk for having an overdose, right? The mindset, as we kind of highlighted a lot of those things. So if somebody's having thoughts of suicide, somebody is based on why they're using the substances, and also the setting. So setting is where they are, who they're with. Using alone is a significant risk factor for having a fatal overdose, right? So if somebody's using substances by themselves and they have an overdose, nobody can intervene. Nobody can give them Narcan. Nobody can call for an ambulance. I also think of, when I think of settings, I think of somebody who's maybe using drugs in a public bathroom, whatever, at a McDonald's, right? So if I go into the bathroom at a fast food restaurant, because that's what's available to me, I have a very short amount of time before people are knocking on the door. So I might be more inclined to maybe take some shortcuts in harm reduction, right? I might not take the time to test the drugs for fentanyl. I might use more over a shorter period of time because I only have a small amount of time, right? And so asking people, this is all just areas that we can ask more ways that we can use our motivational interviewing to learn really not just how much do they meet the criteria for a diagnosis, but learning about their drug use, learning about how they use, where they use, with whom, and doing this in a way which we're also kind of explaining why, because I'm curious to know this because I want to know more about your experience so that we can talk about ways of being safe. It's very different. Okay, so here's a risk formula that we can kind of like come back to and think about. The safety. So I'm going to now kind of like go through the steps of the safety plan, and we'll kind of take a look at that. So step one is things which put me at risk of having an accidental overdose. So we've talked a lot about that. Effectively, we're kind of providing a summary using the client's own language, if because this is something that's for them. If they say, I don't know, if they use a particular term for something, we'll put the term. It doesn't have to be the right term. And then kind of collaboratively decide on which risk factors to use. These could be sometimes, using alone. What I liked about we also did talk a little bit about safety planning in the session on suicide, safer care, right? And thinking about the outliers was something that stood out to me, right? We used an example of like taking a walk is a great coping strategy, but taking a walk might not be available in the middle of the night. So our role is to kind of help navigate. We have some things to keep in mind. We're keeping the risk formula kind of like in the back of our mind. Say, okay, well, using alone is a risk factor. Or are there ever? No, I usually use with other people. Okay, Are there ever times that you use by yourself? Well, yeah, I guess so. Sometimes after I come home, I'm usually using at the restaurant after my shift, during my shift, right? I don't know. But sometimes I'll take some drugs home and I still use when I get home and I'm by myself. Okay, so most of the time you're using with other people, but there are some times that you're using by yourself. What do you think we put it on the safety plan, even though it's not that common? It happens sometimes. Yeah, okay, I'm all right with that. Great. So we'll put it here. I know that's something that you strive not to do, and that's awesome. We can include that as actually right here in step 2. So trying to avoid using alone is a great strategy for step 2, actions I can take to reduce my risk. But let's think about it. What can you do when you are by yourself? And so I would much rather have, I'm not talking to the client, I'm talking to you. This is no longer a role play. I would much rather have on the safety plan something that is practical for that individual than something that they're just saying because it looks right on the safety plan. Using alone is a risk factor, not, so I'm going to put, well, I won't use alone. If that's not realistic to what their life is going to be like, I would rather have something else on here. Like if I'm using alone, I will make sure to test it for fentanyl. If I'm using alone, I will have a plan for somebody to check on me, right? And so this is like, is keeping it real. I want this to be practical for them, not just look good. And so ultimately, what we're trying to get in this first strategy here on the left, using smaller amounts over a longer period of time. Almost everything that is in some way going to reduce the risk in that way. Things that increase risk is more over a shorter period of time. Harm reduction, less over a longer period of time, right? And so that might be trying to just use one substance at a time versus drinking alcohol and other substances. Sometimes using slogans is helpful if this is meaningful to them, like start low, go slow, know your dose, right? Like know what you're taking and what the effect is going to be on you. Sometimes that can also be using a small amount before using, like if you can't test it for fentanyl, but you're not sure exactly what the purity of it is or what the supply was, use a small amount. See if that gives you the effect that you're looking for before taking more. Because once you take it, you can't untake it, right? So you use a little bit, and then you kind of get to know what your dose is for that. Any other harm reduction kind of strategies that you've come across or talk about with people?
Sometimes with polysubstance use, we talk about which substance would be most beneficial to work on first if they're not willing to work on multiple ones at a time.
Okay. Yeah, absolutely. That's a good one. So in how does that relate to when they are using substances? So trying to have them cut down on maybe a higher risk substance. Great. Yeah. Even sometimes the order in which people use drugs, right? So I give an example of that. If knowing that the opiates are the highest risk for having an overdose, using those first, you have a better sense of what the effect of that opiate is going to be. Rather, like if I'm already intoxicated on alcohol, one, I make riskier decisions, right? I'm less inhibition. I'm more likely to make risky decisions if I've been drinking. And then I also am just physically going to have less ability to know what the other substances are doing to me because I'm already intoxicated. So sometimes using the opiates first then using other substances if I'm going to use more than one at a time. So I mean, this is like very different, right, than trying to talk about not use. This is like talking about how people can use in a safer way. We're not encouraging drug use, right? Like this isn't like, hey, go out and try some new things, but this is understanding what people's life experiences and what their practices already are, and we're leaning into that and saying, okay, well, I really want you to stay alive, right? And so these are some things that you can do in the meantime. Your goal may or may not be to stop, but let's look at what can be done to help, that can help keep you healthier in the meantime. Ideally, we're kind of pairing these. So we're identifying some risk factors and that are specific to them. These are not generic, right? We're not just handing someone a pamphlet that says these are risk factors and these are harm reduction strategies. We're pairing them with their actual individual risk factors. And then harm reduction strategies, which are really relevant to them. This is not generic harm reduction. The idea is that we're really thinking about that and things that they're already doing or willing to do that relate directly to their specific situations. Thank you. The balance of the safety plan has a very similar look and feel to suicide safety planning. That's why I really kind of spend the most amount of time in talking about the first steps. The balance of it is things I do regularly or wish to do to stay well. Ideally, you know, this also helps to address the mindset part of risk, right? So if we're helping someone's overall health and wellness, they are less likely to be in positions where they are taking more extreme actions to alleviate that, you know, stress and pain, physical pain, emotional pain. Step 4, people who support my wellness, I can ask for help. Steps 5, this is professionals I can contact in the crisis, and we've actually switched this SAMHSA hotline to 988, which is much easier to remember. But this is where you would be able to put in your program, the contact information, local harm reduction programs, you know, resources that are local to you. Step 6 is the #1 reason I want to live today. So generally, you know, we're introducing this from we're kind of bookending this, the intervention. We kind of introduce it. This is something that I think is important. This is something that we do with people in this situation. However we've introduced it to them, we're bookending that at the end with really ensuring that this is something that is important to them, right? And so eliciting that at the end. This is why do you want to live today? We get a chance to kind of ensure that we're collaborative and have a shared goal. Step 7, the next step I'm willing to take to reduce my risk. This could be something like very concrete. I'm going to get a Narcan kit. I'm going to try these fentanyl test strips that you're giving me. You know, whatever that I'm going to share the safety plan with my roommate. You know, whatever the, you know, is relevant to them. But the idea is that we're really demonstrating like this isn't something that we're just doing to scan in your chart. Like this is something that the intention of it is behind it is action oriented. So how do we integrate safety planning into care? Ideally, you know, early and often, you know, similar to talking about suicide. You know, we want to get this have these conversations as early as possible, even understanding that it might change over time. We can share this across care teams with other people during times of referrals or discharge. Somebody's leaving our program. We mentioned somebody was mentioning working at an inpatient hospital, right? And so doing a safety plan with somebody before they leave through this high-risk transition can be really helpful, and then sharing that with the next program that they're going to. It can inform treatment planning. I highlighted like in the positive coping strategies. Sometimes people really have a difficult time like identifying positive coping strategies, and oftentimes say it's like, okay, well, you know, let's put a couple down here, but this is really good for us to think about. Let's talk about how we can help give you some more tools to deal with this stress. And let's think about that, how we can apply that to the rest of our work, right? And so there we go. And I realize like we are right at time. I always like to just put out some kind of rhetorical questions, I guess, but thinking about how you currently help your clients in getting Narcan, fentanyl test strips, resources. How do you help people get connected with substance use treatment or opioid use medications? Do you or the organization that you work for hold strong beliefs about recovery, abstinence, harm reduction? Sometimes ourselves or the systems that we're working in can actually be some of the barriers to providing people with the help that they need. And so kind of giving some self-reflection to that. And thinking about how you quality metrics, like how do you currently monitor your population at risk for overdose, right? This is just the beginning. We would love to provide more trainings. What we have found is that this is there's a real gap in availability of training, where most people feel like there's a benefit that we've talked with, though the vast majority don't have these types of conversations with people, and primarily that's because they didn't feel like there was things that they didn't have the training on how to initiate these conversations. So we do a bunch of other stuff. We provide zero overdose. We provide trainings, technical assistance. We partner with organizations. There's a lot of like opiate settlement funding that's out there. We really love working with opiate settlement funding, nationals, grants, local grants, foundation grants. So we would really love the opportunity to talk more with you about the programs that you are work with, and if there's ways that we can collaborate together. This is my contact information, and I will put it in the chat also. And I know I didn't save a lot of time, but I can hang out, and if there's any questions or comments, we can make sure that these slides are also available to you, because I put in a lot of resources and hyperlinks at the end.